Okay, welcome everyone. Thank you for joining us for today's EACTA ICU webinar, Can We Avoid ECMO in the Management of Post Cardiotomy Shock? My name is Dr. Philippe Godard. I am the head of the Cardiothoracic ICU department at the Montpellier University Hospital in France. And I am also the chair of the ICU EACTA Subspecialty Committee. So I'm pleased to introduce the two moderators of that webinar. First is Dr. Peter Russell from Brussels, Belgium. He is an EACTA ICU committee member. He is also a cardiac anesthesiologist and intensivist at the Flemish University Hospital of Brussels, with a special assignment as the head of the transformation program of the cardiological care plane and clinical coordination of intensive care. He has a special interest in cardiac anesthesia, intensive care, patient blood management, TE, data registration and quality assessment and improvement, teamwork, anesthesia overseas, and so on. He is a past president of EACTA and served as a representative council member and board member for 16 years. He was an affiliated member at the ACA from 2014 to 2016. He is a member in the SCA and the ECMO, Dutch Association for Anesthesiology. He has more than 50 publications and book chapters. The second moderator is Dr. Daniela Passero, and she is from Turin, Italy, and she's working as a staff anesthesiologist of cardiac intensive care unit in the Department of Anesthesia and Intensive Care Medicine at the Città della Salute e della Scienza Hospital in Turin. Her main activities and responsibilities include organization of clinical activity of cardiac intensive care unit, infection monitoring role also. She has a clinical research activity on postoperative pulmonary complication and pulmonary hypertension in cardiac surgery, critically ill patients with sepsis and acute kidney injury, lab research on septic model and translational research in septic patients and cell culture, organ procurement activity and protective ventilation in lung donors. She is a member as the EACTA Representative Council and ICU and VAD and transplant committees. So now, please, Peter, come to introduce the webinar and the objectives. The microphone is yours, Peter.
Thank you very much, Philip, for this very nice introduction. I'm really excited for this webinar, which I hope you will be very happy with the end. And let me shortly introduce you to the objectives of this webinar. Actually, at the end of which you should understand the current evidence and the best practices, how to use mechanical circulatory support after post-cardiotomy cardiogenic shock, as well as to avoid it. You will get a better understanding of the indications and contraindications, as well as the different types of using ECMO and related devices in the treatment of post-cardiotomy cardiogenic shock. As well, you should understand how can we avoid and how we could use balloon pump, inotropes, and vasoporters in order to have the best treatment for these patients. We will address as well the use of additional forms of cardiac assist, temporary cardiac assist, like ventricular assist devices, and as well you will have a better understanding of how TE should be used in order to help the introduction as well as the proper functioning of this particular treatment. So I hope you were excited as I am about what's coming up. Just to make sure that you use this webinar appropriately, So we will address questions after each of the presentations. So please, if you have any questions, type them into your chat box, and we will bring them up during the presentation, and we will handle them and try to have some time for questions as well at the end. So having said this, it's my pleasure to introduce you the next presenter today, which is Dr. Isabelle Michaux. From Belgium. She is actually a cardiologist and intensive care, and she is head of the cardiological intensive care at the University Hospital of Montgodin, which is affiliated with Louvain. She is very keen on right ventricular function, on which she did presented her PhD, particularly on the echocardiographic aspects of that. And she has been a long time the secretary of the Belgian Society of Intensive Care Medicine, from which she stepped off just this year. And last but not least, she is a very active member of the Intensive Care Subspecialty Committee of EACTA. So it's my pleasure now to give the word to Isabelle, who will discuss the use of alternatives to ECMO in the treatment of post cardiotomy cardiogenic shock. Please, Isabelle, we're looking forward to your presentation.
The use of intra-aortic balloon pump or inotropes for post cardiotomy cardiogenic shock. We can be facing two very different clinical scenarios. The first one is when we are able to preoperatively anticipate that this patient is at high risk of low cardiac output. And we will see that there are risk factors that can help us to detect those patients. The worst scenario is when we are facing a fully unexpected low cardiac output. What are these risk factors? 2 years ago, the group from Novosibirsk published this review paper in GCVA about post-cardiotomy cardiogenic shock. And they published risk factors, pre-op and intra-op. We see preoperative factors are age above 65, LVEF below 50, on-pump surgery, diabetes, chronic kidney disease, and malnutrition. There are some preoperative lab tests as low hemoglobin, low T lymphocyte count, high NT-proBNP and BNP. And there are intraoperative factors like long CPB duration, emergency surgery, and incomplete revascularization. There were also some echocardiographic and MRI parameters that were published as associated with poor postoperative outcome. If based on echo and MRI, we can detect a lot of myocardial segments that are non-viable, a lot of regional wall motion abnormalities, and an ischemic mitral regurgitation, we may suspect that there is a high risk of low cardiac output after surgery. So the balloon. You are probably aware about this well-done randomized controlled trial, multiple centers study that definitely killed the use of the balloon in the cardiologic field. It was about early revascularization of patients in cardiogenic shock because of acute MI. And those authors did not find any differences between the two groups at 1 month and 6 years. May we translate that in our surgical daily practice? Maybe not so easily, because when we look carefully how many people were revascularized using surgery, we see that in both groups it was around 4%. And when we look at the flow chart of this study, we see that there were a lot of crossover between the two arms. There were some patients who were never revascularized because they included some Takotsubo. And the more important point for me is that nearly 87% of the patients who received the intra-aortic balloon received it after reopening of the culprit lesion, which is logical. Time is muscle. However, implanting the balloon after reopening the coronary artery is probably at a time point when the balloon is less useful. What do we find in the literature about the use of preoperative intra-aortic balloon pump and cardiac surgery? I will show you the last two meta-analyses. This first one is about 9 randomized controlled trial. It's mainly CABG patient. However, 2 studies report a mix of valvular and CABG patient. They define high-risk patient as a LVEF below 40%, reduced surgery, unstable angina, left main stenosis, emergent surgery, and recent MI. By the way, nowadays, left main stenosis is no more a risk factor of poor cardiac output after surgery. When we consider the in-hospital deaths, all the studies, they are all in favor of the use of the balloon. If we divide that on pump surgery, once again, positive impact. Up-cap surgery, it seems to be less positive, a little bit neutral effect. And when they consider the more recent published studies, it's once again in favor of the use of the balloon. This is for in-hospital deaths, ICU lengths of stay. Once again, all the studies on pump patient, up-cap patient, in the favor of the use of intra-aortic balloon pump to reduce the ICU lengths of stay. The other meta-analysis is a mix of randomized controlled trial and observational studies, and they define high-risk patient as a severe LV dysfunction plus at least unstable angina or acute MI or shock. And once again, they observed a positive impact of the balloon on 30-day mortality, myocardial infarction, low cardiac output, and cerebrovascular and renal complication. To be honest, we have to take into account this recent study published last year. It's a single-center randomized controlled trial from Brazil. They considered high-risk patients as patients with a Euroscore above 6 and LVEF below 40%. By the way, Euroscore itself is not a predictive factor of poor cardiac output after the surgery. And they excluded patients with cardiogenic shock, recent MI, and there were really few reduced surgery in this study, which is a little bit a problem for me because I believe that this is this group of high-risk patients that can benefit most from the balloon. They used a composite endpoint of 30-day mortality and major morbidity. Once again, there was a lot of crossover between the two arms, but this study was a negative study, no difference between the two groups. So here we are. The big problem is all those studies is that they are mixing very inhomogeneous definition of high-risk patient. When we look at the 2018 ASC guidelines about myocardial revascularization, CABG or PCI, they severely downgraded the routine use of intra-aortic balloon pump in cardiogenic shock, and they just kept as indication the mechanical complication of acute MI like VSD or rupture of papillary muscle of the mitral valve. About the surgical use, perioperative use of the balloon, they concluded that the literature was still in favor of the use of the balloon in terms of mortality and morbidity. However, emerging high-quality randomized controlled trials are contradicting this result. So we are waiting for some more randomized controlled trial. When should we implant the balloon? If you implant it early in the OR. So this is data from the group of Marco Ranucci about CABG and valvular surgery, and they looked at the 30-day mortality. So the best survival rate is observed for those who will not receive the balloon, but for those who receive the balloon, you observe a better survival rate for those who receive it early in the OR. This other study is coming to the same conclusion concerning the outcomes in hospital mortality, median time on the ventilator, and median ICU length of stay. The best option is to receive no balloon, but if you receive it, you should receive it preoperatively. And on the total hospital length of stay, you have the shortest length of stay for those patients who will not receive the balloon, and you have the longest length of stay for those who receive it postoperatively. Is there a place to associate the balloon with VA ECMO? Maybe. This is a case series published this year about peripheral VA ECMO in 10 patients. You see, before implantation of the intra-aortic balloon, after implantation of the VA ECMO, all these patients had a closed aortic valve. And we all know it's really a challenge to keep the aortic valve opening. They were implanting the intra-aortic balloon pump, and in 8 of those 10 patients, they observed that the aortic valve was reopening. Same data or same observation in this national database coming from Japan. They compared the group receiving VA ECMO alone with the group receiving the balloon plus ECMO. And they compared the 1 month mortality rate and the success rate of weaning from bypass. And once again, they observe a statistical significance in favor of the use of the balloon plus ECMO on 1 month survival rate and success rate of weaning from ECMO. Why? Probably because these two devices are not working against each other, but are more mutually supportive themselves. And this is an editorial about the hemodynamic effects of both techniques. And we see on the afterload of the left ventricle, on the myocardial oxygen consumption, the association of the two techniques result in a neutral effect, what we are looking for. Inotropes. We all know that categoric inotropes have a poor impact on the survival rate of our patient. This is a registry coming from Denmark, and this is the cumulative mortality risk at 1 year. And we see if you receive no inotropes, you have the best survival rate. If you receive it intraoperatively, it's still okay. But if you receive it postoperatively, you are increasing your mortality rate around 13%. And keep in mind, if you choose a categoric inotrope, the worst option is epinephrine. Okay, this is a cardiologic field, that's cardiogenic shock after acute myocardial infarction. But the authors clearly observed that if you use epinephrine compared to norepinephrine, you will sustain and maintain more often the patient in cardiogenic shock. So we are looking for non-categoric inotropes, and it's maybe the right time to think about GIK, glucose, insulin, potassium. This randomized controlled trial was published last year and is coming from Geneva. They included elective CABG patients with or without aortic valve replacement with a Parsons score above 7. They excluded emergent surgery, OPCAP, uncontrolled diabetes, child C, and dementia. Those patients were randomized to receive at the time of induction of anesthesia either saline control group or a cocktail of 50 ml of G40 plus 20 units of actrapid and 10 mg of potassium. And this cocktail was infused over a 1 hour period of time. And the primary endpoint was occurrence of post-cardiotomy ventricular dysfunction, and they defined it as a TEE-guided need for inotropes or intra-aortic balloon pump. What did they observe? In the GIK group, they observed the lower incidence of post-cardiotomy ventricular dysfunction. They observed no differences on mortality, but it is really a small sample size. In the GIK group, they also observed the lower complication, cardiovascular and respiratory complication, and it is in the GIK group that they observed at day 1 the lowest troponin I peak. They also observed in the GIK group the shortest ICU and hospital length of stay. And when we look on the left ventricular fractional area change, baseline before surgery and after chest closure. In the control group, they observed a systematic drop in the left ventricular fractional area compared to the GIK group, where they observed a significant increase. So for years, we know that GIK is a positive inotropic agent. This is a meta-analysis about the reduction in cardiac index when the author compare the pre-bypass and post-bypass. And you see, when the authors compared the GIK group with the control group, they observed a lower reduction in the cardiac index, or even a significant improvement in cardiac index in the GIK group compared to control group. This is a meta-analysis about the impact of GIK on the incidence of myocardial infarction. And once again, it's in favor of the use of GIK. Other non-catecholagic inotropes is the phosphodiesterase 3 inhibitors like milrinone. Indeed, it's not acting through the beta-2 receptors. However, it's still acting through cyclic AMP. Milrinone is clearly inducing more vasoplegia than dobutamine. I was a little bit puzzled and concerned when I read this retrospective cohort study coming from Denmark, from the group of Carl Johan Jacobsen. They compared the 1 month and 1 year mortality between patients receiving dobutamine and receiving milrinone. And they observed a systematic increase in the mortality rate 1 month, 1 year in the group receiving milrinone. I'm sure you are expecting me discussing levosimendan. On a pharmacological point of view, it is a phosphodiesterase 3 inhibitor, but it has specific properties, which is to be a calcium sensitizer. So no doubt it is a very potent positive inotropic agent. However, there is a price to pay, and when you start levosimendan, even without any bolus, the first hours you will be facing some vasodilation, and it's some hours after the start that you will see the positive inotropic effect. It has positive impact on the function of the mitochondria, creating a cardioprotective effect. And we all know that it has some active metabolites with very long half-time, which could be a positive, but sometimes a negative point. What about the meta-analysis about levosimendan versus placebo? I put placebo in bracket because that's never really with placebo. The majority of those studies were accepting the classical inotropes in both arms. When we consider the mortality, the effect of levosimendan on mortality, in the group with preserved LVEF, we have no impact. It's only in the group with reduced LVEF below 50% that we have a positive impact of levosimendan on the mortality. It has also a positive impact on renal replacement therapy and on the occurrence of low cardiac output syndrome. This year was published this meta-analysis. This meta-analysis is including the last 3 large center randomized controlled trials that were published, and they were all negative studies. When we look once again on all-cause mortality, it's in favor of the use of levosimendan. But if we divide these studies according to the risk of bias, if we consider the 3 last randomized controlled trials that were published, because they are considered as low risk of bias, we see that positive impact is less clear. So the large positive impact is coming mainly from the studies with a high risk of bias. This study also focused on the timing of administration concerning the mortality rate. So if you consider using levosimendan, please use it preoperatively. It is not a rescue drug. The conclusion of this meta-analysis, however, is less optimistic because they considered that the quality of evidence was low, and they calculated the TSA. It's a trial sequential analysis. It's a statistic tool. Let's say it's the price we have to pay to be allowed to do repetitive testing on accumulating data. And they concluded that this TSA was inconclusive. So their conclusion was neither supporting or against the use of levosimendan as a prophylactic drug to reduce mortality rate in patients with reduced pre-op LVEF. And once again, they are claiming for future multi-center, well-done randomized controlled trial. To be honest, we should focus a little bit on this negative trial, that's the LEVO-CTS trial. They just found a positive impact of levosimendan on the lower rate of low cardiac output syndrome. But when they did a post-hoc analysis focusing just on isolated CABG and considering the 3 months mortality rate, they observed a more favorable outcome for the CABG patient. They received levosimendan. Is there a place to associate levosimendan with intra-aortic balloon pump? Once again, that's the group of Lomirotov. They considered patients with very poor LVEF and created 3 groups. Group receiving just intra-aortic balloon pump, group receiving intra-aortic balloon pump and levosimendan, and a group receiving just levosimendan. 2 significant points. It is in the group that just received the intra-aortic balloon pump that they observed the highest peak of troponin I, and it's the group that received just levosimendan that they observed the shortest ICU length of stay. For all the other parameters, there were no differences between the 2 techniques. So, to conclude, we should, as much as we can, try to anticipate, detect preoperatively those high-risk patients using the risk factors that we use. Concerning the intra-aortic balloon pump, the literature is still in favor of the use of the intra-aortic balloon pump in those high-risk surgical patients. If we use it, we should use it preoperatively, and there is maybe a place to associate the balloon with VA ECMO. Considering inotropes, it's maybe the time to rethink GIK. Is milrinone really increasing the mortality compared to dobutamine? And personally, I'm still looking for the right niche for levosimendan. So I thank you for your attention.
So thank you very much, Isabelle, for this very nice presentation, which actually is showing the importance of getting the basics right before we are actually using ECMO in our patients. I'm looking to the questions which come from the audience, and the first question I can see is, do you think is there any role of the inotropes and vasopressors that improve survival in post-cardiotomy cardiogenic shock?
That's a very good and large question. I'm not sure there is the right answer. Of course, there are data in favor of the use of levosimendan to try to improve the survival rate. And I think I'm a little bit puzzled by the last 3 negative randomized controls trial. We need more information. What is sure is when we are using the classical catecholamine agent like dobutamine, epinephrine, I'm really convinced that we are more killing our patients. But the magic bullet, as far as I know, does not really exist. We need more research. To be honest, I do not know. In terms of vasopressors, that's a little bit out of the topic of today, but probably norepinephrine is also at a very high dose in case of severe vasoplegia, not the best option either. Vasopressin is maybe better, but we have to keep in mind that vasopressin can vasoconstrict mammary arteries and however create some ischemia, myocardial ischemias. To be honest, I'm not aware about all the studies. Maybe there are some, but I think there is no magic bullets in terms of inotropes or vasopressors.
Okay, thank you. Another question, and I think you touched the subject, is actually the interaction between the balloon pump and ECMO, and it's a question from Dr. Pradeep Kumar Pillai, who is actually addressing, when you have a peripheral veno-arterial ECMO, how does that balloon pump inflation and deflation actually may hamper the retrograde flow of the VA ECMO?
We have really in our center few experience with that. So the only times when we use it with a central localized VA ECMO. So I can imagine that maybe as you can compromise some vascularization of the left subclavian artery or carotid arteries, if you push the intra-aortic balloon pump too far away, we can observe maybe the same thing. I'm not aware, but maybe I missed the right literature about that it's really the association of peripheral intra-aortic balloon pump and a peripheral VA ECMO can significantly compromise the upper perfusion. But to be honest, I did not went through all the literature. So if somebody has more experience in that, I let him to answer to that question. So in our experience with the central one, we did not create a compromise of the upper part of the body.
I think there's some evidence, but I think it will be touched upon one of the further lectures, as you were actually alluding. Another question is coming about the glucose, insulin, potassium. This is already a long-standing issue, and personally, I've been using it as well. Would you think, according to your going through the literature, it's actually some standard type which we should use a standard way to patient? This is a question from Jeroen Wink.
It's not standard care, for sure not. And as you, even if I'm younger than you, I heard speaking about GIK for a long period of time. It's an inotropes. We know it from toxicologic and cardiologic literature. So I'm not telling that we should replace everything like the butamine or levosimendan by GIK. That's not my purpose. But maybe we could add that to our armamentarium. And I found quite elegant the way the group of Geneva use it as an infusion, 1 hour infusion at induction of anesthesia. It's just maybe reopen the option and think about, but I'm not telling that's the best option neither.
Yeah, well, I think so. It's indeed very interesting subject, and personally, I think it's the longer you use it, the better it is, because it has to increase it has to provoke some metabolic effects, and that will not work immediately, and particularly when you have myocardial ischemia. Maybe this is to what extent has glucose, insulin, potassium been used together with other inotropics, which is a question from Ahmed El Sombati. To what extent is the inotropic effect of glucose, insulin, potassium in addition compatible with the use of dopamine? Does it potentiate each other? Does it annihilate its effects?
I think so, because the way they are working is very different. I think the butamine is consuming the fuel of the heart, which is ATP, and glucose is giving to the cell the option to restore the reserve in ATP. So they are complementary. Yes, I think so. On a physiological position, yes, for sure.
Well, I think to make comment on that, actually, the fact is that like all studies of inotropics, and I don't know what would be your impression about this, we really do not know how it really interacts. And I think you alluded to the literature that there is so much heterogeneity that actually we do not know. There is not much proven evidence of how actually inotropics and how inotropics should be used.
For sure.
Would you agree with that?
I think even if we consider the butamine, that we use it quite largely for years, but as far as I know, there were never a randomized controlled trial about the use of the butamine. Maybe the butamine would never have come to the market at this time period. If we do randomized controlled trial, it could be negative with the butamine. I fully agree with you. We try to do our best, but we do not really know what we are doing with inotropes. That's for sure.
I have a question from myself, Dr. Michaux. Is actually you have a lot of experience in right ventricular failure. And I personally, as a cardiac anesthetist, think that right ventricular failure is one of the reasons why patients do not come off pump appropriately, and that we may use ECMO inappropriately. What would be the role of treating right ventricular failure before addressing immediately ECMO? What would be your therapy in this for these patients?
You mean in an acute setting, difficult weaning from bypass with RV dysfunction?
Yeah.
I think we need inotropes, and the levosimendan needs some hours to be efficient, so it's not a rescue drug. If you can anticipate that, you know that your patient preoperatively has a poor right ventricle, I would personally, and we have experience with that, choose levosimendan. In the emergent setting of getting out from bypass, we have milrinone, which has also very potent vasodilatory effect on the pulmonary artery, what we need. We should use some agent, inhaled agent, to reduce the pulmonary pressures, maintain the pressure in the aorta to perfuse the coronary artery, and sometimes the intra-aortic balloon can help us to maintain the perfusion of the coronary artery. Otherwise, we should use norepinephrine, vasopressin maybe, which has less vasoconstrictive effect on the pulmonary artery. So inotrope, vasopressors, and vasodilators of the pulmonary artery.
I hope that with this webinar, we've been able to provide you with a good overview how ECMO can be used and should be used, which are the caveats, and as well that ECMO should be seen within a whole arsenal of therapies. And I think that basically Dr. Antonio Rubino from Papworth, the UK, he explained very clearly the basics of ECMO treatment. He addressed as well the risks and the complications which are involved, which are really vast. And actually, he was mentioning, like other lectures, that the outcome after post-cardiogenic shock in patients who need ECMO is not very good. And in the best centers, it approaches somewhat about 1/3 of the patients who recover from ECMO. However, this is very dependent, as he mentioned, upon a very good selection. He insisted on the fact that such selection should be a multidisciplinary decision. And I think his final words was actually that every patient is different, ECMO is complex, and for every case we need a tailored approach in order to have the most benefit and avoid the side effects. Next was Dr. Isabelle Michaux from Brussels, Belgium, who gave us an overview of post cardiotomy cardiogenic shock. She mentioned the heterogenic literature, which is very difficult to interpret and to provide evidence what's the best treatment in this situation. She reviewed the use of balloon pump, which should not be dismissed lightly, and is probably very valuable, particularly in the preoperative setting in these high-risk patients, as well as in combination with ECMO in order to provide afterload reduction, which may be a major problem with ECMO. She reviewed as well some of the inotropics. She pointed out to the risk of very high doses of epinephrine. She mentioned let's say, somewhat care we should have with the use of milrinone. She reviewed as well levosimendan, which was very promising, but still waits to find its niche where it is most useful. Again, here preoperative setting, it's probably the best way to use it. Next was Dr. Ouattara from Paris, who explained that next to ECMO, we may use other treatments, other assist treatments like ventricular assist device, be it left ventricle, right ventricle, or biventricle. And this should be seen more as, let's say, a second approach after the ECMO in order to bridge to something else, maybe an assist device for when you're likely in heart transplant. He reviewed as well the Impella device, which is very promising. Particularly, we know the high flow variants, as well the Impella which you can insert surgically from within the apex or through sternotomy, as well as the new upcoming Impella for right ventricular assist. All very promising, but still very early phase studies. Dr. Priya Menon from Leipzig gave us a good review how TE guidance should be used in the insertion of ECMO cannulae, balloon pump, as well as Impella. Not only insertion, but as well in the daily follow-up of this patient, TE guidance is of paramount importance. Finally, Dr. Philippe Godard, he gave us the viewpoint from the intensive care to these patients. And with that, I think, I hope we have given you a good overview, which will allow you to make better use of ECMO in your patients. I really hope that you enjoyed this webinar. I wish you a very good evening. Thank you for your participation from wherever you are listening or looking. And now I'm giving the final words from this webinar to Dr. Godard. Dr. Godard, the webinar is yours.
Thank you, Peter, for this point-by-point wrapping up. Now, I think we are good for now. Thank you, everyone. It was a pleasure being with you today. As a take-home message, I would like to say that VA ECMO for refractory post-cardiotomy cardiogenic shock needs to be started early when inotropes don't work, and needs to be customized to patient and surgical situation, including a combination with intra-aortic balloon pump. Left ventricular unloading is mandatory, and minimal pulmonary flow needs to be preserved as much as possible. Anticipation or prevention is a key point for the use of balloon pump and probably levosimendan in selected cases. Selective left ventricular support or combined ventricular assist devices are promising options. TE is absolutely essential for the indication, the setting up, the follow-up, and the winning of mechanical circulatory support. It's time now to close the session. On behalf of all speakers and moderators, I would like to highlight and emphasize the value of Professor Mohamed El Tahan as EduCom Chair, being instrumental in organizing this EACTA webinar. This is my pleasure to introduce Professor Fabio Garacino, the President of EACTA, to conclude and close the webinar. Please, Fabio.
Good evening, everybody. Dear colleagues, due to unpredictable technical problems, I'm not able to lively connect with you at the end of this webinar, but I really wanted to thank all the people who made this webinar happen. So it is a pleasure for me, on behalf of the EACTA Board of Directors, to thank the speakers who did an excellent job, and we are very grateful to them for their commitment to EACTA. We know how hard it was to prepare the lectures, to go through the rehearsals with Professor El Tahan in order to make everything work fine tonight. So many thanks to all the excellent speakers. A special thank to the ICU subcommittee. All these educational activities are prompted by our subcommittees, are supported by the subcommittees, and we are very grateful to our colleagues and friends in the subcommittees for supporting these educational activities. I really wish to thank a lot the sponsors who supported us and allowed us to make this webinar possible. So I really thank Abiomed and Orion Pharma for their support. We are really grateful. They are supporting not only this webinar, but in general our educational activities and scientific activities. And so we consider them really part of this team producing education and scientific activities for our community. Let me thank the team from Rome, the team from AIM, our association management team. They did an excellent job in supporting and backing all this activity. And last but not least, as we used to say, a great thank to the educational committee of EACTA and to its chair, Professor Mohamed El Tahan, who is so active and is supporting, promoting, and managing all these interesting educational activity. Many thanks. Well, we apologize for not addressing all the answers. This is due to the limit of time, but EACTA will publish all the answers by speakers on the website. So before saying goodbye, I really wish to remind all of you that the next EACTA webinar will be in March 2020. So keep on following us. Thank you so much for attending and joining. Bye-bye.